I'd like to welcome everyone here today to only our second ever virtual Dean C. Laycock Perspectives in Medicine lecture. GBMC has been offering our Perspectives in Medicine lecture series for more than 20 years. This is just the second time we've hosted it virtually. A little bit of history behind our program if you're joining us for the first time. In 2012, this lectureship was named after one of its staunchest supporters, Mrs. Dean C. Laycock, a retired vice president, investment manager at the Fiduciary Trust Company in Boston. Like some of you, I was fortunate to know Dean personally and call her friend. She was a member of our Elizabeth Yagi Society, Joseph Keelty Society, and 1965 Society. She became familiar with GBMC after, as so many of our folks do, after a wonderful relationship that her husband had when he was being treated for cancer under Dr. Marshall Levine's care. Her husband, Zane, who had lung cancer, he had such a life-changing experience at GBMC under Levine's care that Dean Laycock inserted a provision into our estate plans for GBMC in the same manner as one of our founders, Elizabeth Duncan Yagi, had done in the 1970s. So if you're interested in adding a provision to your will or trust, or maybe you would like to make a gift that will pay you income for the rest of your life, please let me know after the program, and I'll be happy to share more about gifts to GBMC that are made with your estate and financial plans in mind. So today, as you know, our lecture is entitled Treating Disorders of the Aging Voice, and we're pleased to present our speaker, Dr. Shumon Dhar, and we're happy that you are all here with us this afternoon. My name is John Jeppe, and I'm the Senior Director of Principal Gifts at GBMC. So before we begin our program, we'd like to go over some housekeeping items. We ask that you keep your phone or computer on mute for the duration of our speaker's remarks. If you have questions, you can type them into the comments screen. It should be off to your right, and there's a little block at the bottom of your screen that should say chat. If you click on that, you'll be able to enter your comments in there. We'll be able to see them. So you can put your questions in there at any time, and when we have an opportunity, Dr. Dhar will get a chance to answer them. So first, what we'll do is at the end of the formal presentation, Dr. Dhar will have the Q&A, and he'll answer all the questions from the webinar comment screen, and then we'll switch over to the folks who are on the phones and give you all an opportunity to ask as well. So to make a few general acknowledgments, I want to thank Nick Overfelt and Megan Ecker, who have taken good care of us and all of our audiovisual and technical needs for today's presentation. Without Nick and Megan, we would not have been able to take our Dean C. Laycock Perspectives in Medicine lectureship virtual today. So thanks again, Nick and Megan. We'd also like to welcome a few distinguished individuals to our program. GBMC Healthcare Board member and one of our regular attendees at these lectures, Mr. Delbert Adams, joins us again today. So welcome, Delbert. GBMC Foundation Board member and another loyal attendee, Dr. Joan Wang, is here. Dr. Wang, always great to see you. Welcome, Dr. Maria Payne, an amazing physician. She's a neonatologist in our neonatal intensive care unit, something that's close to my heart. My son was born there 20 years ago. Doing well today, I might add. Glad you are with us, Dr. Payne. And we're also happy to welcome back members of our Keelty and Yagi Societies, Dick and Mickey Price, Mark Harris, and Bob and Pat Wagner. Welcome. Also joining us are Yagi members Caroline Jeppe, Lydia Hoover-Stickley, and Betty Howe. Since we've gone virtual, Betty Howe is back again, an Elizabeth Yagi Society member and retired GBMC volunteer. Betty and her late husband, Bill, a veteran of the Korean War, more on that later, literally volunteered at GBMC for thousands of hours. Since Betty moved to the west side of Baltimore, she's not been able to make it to our Laycock lectures, but since we've moved to a virtual platform, Betty has rejoined us. And I think it's also worth noting that we have another history-making moment here. One gentleman is joining us all the way from California. Now that is a first. Welcome, Dr. Alan Abrams. You get the prize for the longest distance, in quotes, traveled. Welcome also to all of you who are at GBMC and Gilchrist volunteers. We miss all of you and can't wait to get you back into the hospital after the COVID crisis is behind us. And finally, I'd like to thank my boss in GBMC Philanthropy Department VP Jenny Coldarn and my colleague Morgan Varley. We would not have been able to do all this, host this virtual webinar, and give you the wonderful goodie box. I'm not sure if that's showing up, but they should have been delivered to all those in their immediate area. Dr. Abrams, we couldn't make it out to you. We're sorry about that, but if you get back in touch with us, maybe we can hook you up a little bit later. So thanks one and all for your support and service to the institution. Finally, today is Veterans Day. Our veterans have raised their right hand and sworn an allegiance to our great nation. We honor anyone who has worn the cloth of his or her country on November 11th each year. So I know we have several in attendance today, and quite a few are here in spirit. You may not know that November 11th was chosen as the date for Veterans Day because it was at the 11th hour of the 11th day of the 11th month in 1918 that the guns finally fell silent and the terrible war, which was then known as the Great War, came to an end. Today we call it World War I. So if you are or were ever a member of our armed forces, we thank you for your service in the U.S. military. Now, you can't hear us because our PCs and phones are muted, but you have our applause. Yay! Thanks again to all our veterans, living and deceased. Now onto our program. Dr. Shumon Dhar is board certified. He's a laryngologist located in Baltimore, Maryland, who specializes in the treatment of voice, airway, and swallowing disorders, dysphagia. Dr. Dhar earned his undergraduate degree from Sophie Davis School of Biomedical Education, City College of New York, magna cum laude, and earned his medical degree at Stony Brook University School of Medicine. Upon completion of his residency in otolaryngology and head and neck surgery at SUNY Upstate Medical University, Dr. Dhar completed a fellowship in laryngology and bronchoesophagology at the University of California, Davis, UC Davis. Dr. Dhar is a member of the Airway and Swallowing Committee of the American Academy of Otolaryngology, head and neck surgery, as well as an executive council member of the Maryland chapter of the American College of Surgeons. Ladies and gentlemen, we're pleased to introduce Dr. Shumon Dhar to present Treating Disorders of the Aging Voice. Dr. Dhar, you can take yourself off mute and the floor is yours. Thank you.
Great. Thank you, John. I really appreciate that very nice introduction. Thank you for having me. It's a really big honor to be able to address this fine group of individuals, and I'll get right to it. And what I'll do is give my presentation, and then certainly really happy to discuss particular questions that the audience has. And I like to make this as interactive as possible. The way I learn best is whenever I can apply something to an individual patient. So that's kind of how the talk is going to be structured today. I'm going to talk about individual patients that I've seen relatively recently, and then we can talk about how this really affects all of us as we get older. So I'm going to right now do my sharing of the screen here. Okay, well, let's get started. So we'll start off with one of my patients, 59-year-old man with complaining of a hoarse voice. So I get a call Sunday at 11 a.m. That this gentleman, who's a part-time rock and roll singer, complaining of a significant change in his voice quality. So I agreed to meet the patient in my office, and he was telling me that there was a sudden change in his voice quality after a rehearsal. He denies any pain, no trouble swallowing, no trouble breathing, and he's in the middle of a national tour, and he had also been recovering from a recent upper respiratory infection. So he's concerned about his voice and is wondering, is the voice change going to be permanent? What's going on? When I take a look at the gentleman, his exam is relatively normal. When I see him, voice sounds very hoarse, very rough, and very weak. He's unable to hold a sustained long vowel like E, and he has a lot of fatigue when he uses his voice. One of the common ways we examine voice is first we use our ears and we listen to the patient, but then we need to take a look inside and see what exactly is going on with the larynx, also known as the voice box. We use a special camera that can be the camera can either be put through the mouth, or a flexible camera can be put through the nose. And this camera has a light at the end of it and allows us to record the vocal cords. So here's a picture of our patient. And you can see the vocal cords moving and vibrating. Okay. And so based on that, we made our diagnosis, which was a right-sided vocal cord hemorrhage or bleed underneath the skin of the vocal cord, which was also associated with what's called a polyp, which is a benign lesion that occurs from trauma of the vocal cords from singing or talking excessively in a certain way. So whenever we see patients who have a bleed underneath the vocal cord, this is considered a vocal emergency. And we have various algorithms to treat patients with these vocal emergencies. So the primary way to treat vocal hemorrhage or a bleed underneath the skin of the vocal cord is strict voice rest. So we recommended that this gentleman have 7 to 10 days of strict voice rest until all the blood has resorbed. Basically, you can think of this as a little bit of a blood blister, and we just need time for the body to resorb the blood, and then things get better. However, the polyp that is associated with that bleed is going to remain, and only after all the bleeding has resorbed do we consider intervening and surgically removing the polyp. So the differential for a patient who comes in to see me with hoarseness is quite broad, from traumatic causes, cancer, infection, inflammatory causes, problems of the endocrine glands, problems after surgery. It's very broad. And so there's so many things that we need to think about when we see patients with hoarseness. And what I'll try to do is give you a sense of how I work these patients up and how I stratify what to do with these people. So again, as John said, today we're going to be focusing on the care of the aging voice. There are some conditions that are more common in patients who are older, but many problems that we see in old age, we also see in patients of middle age or younger. And so everything is not specific to the older population. However, these are the concepts I do want to stress. So before we get into kind of the specific disorders, I want to briefly give everybody a little overview of what we're talking about. So as John said, I'm a laryngologist, which is the branch of ear, nose, and throat surgery that deals mainly with the throat. And the throat does 3 things, and they're all important. Number 1, the throat is controlling breathing. The vocal cords open and close when we breathe in and out, and it regulates breathing. It also regulates the swallowing and the protection of the airway when we swallow. When we take a swallow of food, our vocal cords close and our throat closes up so food doesn't go down the wrong way. And then our third function of the throat or the larynx is phonation, which is another word for talking or speech. And that is the most recent evolutionarily function of the voice box. So number 1, the most important thing is breathing. Number 2, swallowing and getting nutrition. And number 3, voice. And so the care of the voice is also involved in the care of swallowing and the care of breathing, and basically creating a equilibrium between those functions. So this is a picture of what the vocal cord looks like under the microscope. And what I want to stress with everyone is that the vocal cords are these flaps of tissue that come together when we talk and open when we breathe. There are different layers of the vocal cord. What I would stress to everyone is that there's a cover layer, which is the vibratory layer, and then underneath the cover layer is a ligament, which attaches to the muscle. And so the muscle and the ligament is involved in movement of the vocal cord in and out, and the cover layer is involved in the vibration and the creation of sound. And underneath that cover layer is this jelly layer. And that jelly layer is what's called the vibratory layer, which is very important in the creation of voice. Voice all starts not at the vocal cords, but it starts in the lungs. When we take a deep breath in, we fill our lungs up with air, and then we breathe out, and we create air pressure underneath our vocal cords. Our vocal cords close, and then the air pressure builds up underneath, which causes vibration of the vocal cords when they're together. And that's how phonation or voice works. As I told you before, the vocal cords are muscles that open and close and tighten. They're controlled by nerves that come from the base of our skull and from our brain. These are called the cranial nerves. The cranial nerves come out of the skull, the base of our skull, go down into our chest, and then loop back up to our vocal cords. The most important nerve is the recurrent laryngeal nerve, which is the most important nerve in movement of the vocal cord. There are also other nerves called the superior laryngeal nerve, which causes the vocal cords to tighten, which allows us to get our higher pitched voices. So who are our patients? When we're talking about elderly patients, we see patients who are retired from their jobs, but we also see patients who are still working. We see patients who use their voice professionally, and these are not singers. These are singers, lawyers, doctors, call center people, business people. We see a lot of cancer survivors at the dance center here, patients who've had head and neck cancer, breast cancer, brain cancer, all different things that have voice problems. And then we see patients with who have other comorbid medical problems, patients who have difficulty eating and are losing weight, patients who have neurological problems such as stroke or Parkinson's or ALS, patients with recovering from recent chest or lung surgery, patients who have gastrointestinal problems like acid reflux disease, and also patients who have lung problems like asthma and COPD, and patients who are smokers. And so I don't treat patients just in isolation. I treat my patients with a team here at the Dance Center. My team includes my fellow laryngologist, Dr. Lee Axt, our speech language pathology team, who are fantastic, and we have special people who specialize in singing, in professional voice. We have people who specialize in swallowing and head and neck cancer rehabilitation. And so we have a great team here at the Dance Center. And so it's not just me, it's me plus a team of people. And so when I see patients who come in, I need to get a good history and see, well, what do they use their voice for? What are their goals? What are their commitments in terms of their voice use? Do they have other issues like breathing or swallowing problems? And are they a smoker or alcohol drinker? As I said before, we need to get a good history because many other medical problems can lead to voice problems. And so I always get a good history from lung problems, neurologic problems, rheumatologic or autoimmune diseases, learning about the patient's or family's history of hearing loss. All these things are important with voice. I also need to know, well, are the patients on any medications? Have they been treated for their voice problems before, and for how long? Have they ever had voice surgery before? Have they ever had a general surgery where a breathing tube was placed between their vocal cords during an operation? Have they ever been on mechanical ventilation and being on a breathing machine? Have they ever had voice therapy? And then I always do, before going in and looking at the voice box, I do a complete head and neck exam. I listen to their voice. I listen for strain. I listen for hoarseness. I listen for breathiness. I evaluate the nose. I evaluate the mouth. And I evaluate the neck. And then the most important part of our exam is the camera exam. It's called video stroboscopy. What it is not just a look with a camera, but the camera has a flashing light, which then corresponds to an audio recording that we're taking of the patient. And the light shines and flashes out of phase with the frequency from their voice, which allows us to see their vocal cords move in slow motion. Here's an example of what a normal voice box looks like. You can see the vocal cords in the middle doing a nice vibration. And then when the patient glides, the vocal cords elongate and tense up, and we have a higher sounding voice. So let's carry on with some patients, and we can discuss what's going on and how ear, nose, and throat doctors or laryngologists can help. Okay, so let's see here. So we have a patient comes to see me, 74 years old with weak sounding voice, worse over the past couple of months, but it's going on for a couple of years. Patient's always also complaining of swallowing problems and food getting stuck, and also a lot of secretions in the mouth. The patient has a history of Parkinson's disease and is taking a Parkinson's disease medication. So I see the patient and I do an exam. And one of the things I'm seeing here is a lot of debris in the larynx. And actually what we're doing now is you can see I'm using a special cannula that is going through the mouth, and I'm spraying numbing medication all along the larynx with my special cannula that's spraying lidocaine and numbing up the voice box. I'm having the patient talk while I'm putting in the lidocaine. One of the things that I want everyone to take note here in this patient with Parkinson's is that the vocal cords are very thin. There's atrophy or thinning of the vocal cord muscle, and there's a lot of weakness of the voice box in terms of the ability to get sound out. Oftentimes we see Parkinson's patients with a very low sounding voice. And this is pretty common. And they also have problems with swallowing and swallowing their own secretions, which is why they have a lot of drooling. And so in this, what you're going to see at the end of this video is this patient has had a very weak voice and swallowing problems. And so what we decided to do is offer this patient a procedure where we injected the vocal cords with a special filler agent to plump the vocal cords up so they're not as thin, and so they close better, and we get a louder voice and better swallowing. Go to the end of the video. After we've numbed up the vocal cords with our special numbing medication, we use a needle and we go directly into the vocal cord with our needle at the most lateral position, and we inject deeply into the vocal cord muscle a filler agent. This is all done while the patient is awake. And we do a nice slow injection of filler agent in both vocal cords. And here's us doing the injection on the other vocal cord. And we're doing a nice slow injection. And this is only possible after numbing up the vocal cords with lidocaine. And you can see that vocal cord slowly filling up, and slowly it's going from a concave shape to a convex shape. And this is going to allow this patient to have a much better voice. And it's also going to allow that patient to have better swallowing, because when we swallow, our vocal cords close and to protect our airway. And I'll show you a picture of the vocal cords after our injection. And you can see the vocal cords have a much better medialization, and they completely close now. And you can see that that's a much better voice. So the next patient I'll talk to you about is a patient who has another older patient who has complaints of roughness and raspiness. This occurred about 2 months ago, according to the patient. An ENT before me took this patient to the operating room and took a biopsy. The biopsy came back squamous cell carcinoma, which is actually a type of cancer that often affects the vocal cords. This patient had a very significant smoking history as well, but had quit about 5 to 10 years ago. This is going to be a picture of the patient's voice box. You can see the patient is having a tough time getting a voice out and is straining significantly. On the right vocal cord, you can see there's a lot of evidence of irregularity of the vocal cords, and the vocal cords are not vibrating very well. Normally, we see a nice vibration of that floppy layer, the cover layer, over the muscle, but here we're not seeing any vibration on the right vocal cord, which is the left vocal cord on the screen. And so that's an example of what a vocal cord looks like with cancer. And so we took this patient to the operating room and used a laser to remove all of the cancer. And this is up top is what the vocal cords look like before the operation. And then at the end of the operation, we had cleared all the cancer off the vocal cord. This is another patient that I saw also quite recently with what initially looked like a vocal cord polyp, which is a benign lesion that we saw in the first patient that I talked about. However, this patient also had a difficulty in terms of vibration of the vocal cord. When we see patients who have stiffness and vibration of the vocal cord and a smoking history, our antennas go up that this could be something more than just a polyp. And so we took the patient to the operating room. We used a special laryngoscope to visualize the larynx, and we removed the lesion. And then we used the laser to remove the stiffness of the vocal cord, and then we took more biopsies. As it turns out, that also came back cancer. And so what that illustrates is that sometimes even what we see with our two eyes doesn't tell the whole story. And so only a biopsy can really reveal what the true nature of the illness is. And when we see that, we attempt to take the entire tumor out through the mouth using special lasers and laryngoscope technology. There are different types of cancer of the vocal cords that can occur in older people, as well as people who have a significant smoking history. And the tumors can be rated on a scale of 1 to 4, from small tumors of the vocal cord to T2, 3, and 4, where the tumor extends beyond the vocal cord to other parts of the voice box. We are able nowadays to use different laser technologies to remove the vocal cord tumors, and studies have shown that removing tumors with surgery rather than radiation, the overall survival rate is relatively the same, but the likelihood of preserving your larynx and not needing aggressive surgery down the line is better with endoscopic surgery. And so we can talk more about that later. Another patient I saw recently is a 57-year-old patient who had several years of hoarse voice and is working for the government and uses his voice daily on Zoom presentations like a lot of us are doing these days. And here's a picture of what we saw. Here's the camera going through the nose, and then it goes down the back of the throat. And what we see here in the throat are lesions of the voice box in this business person. There are 2 lesions on both sides of the vocal cords, and we can see them causing a significant blockage of the voice box, and they almost have a pock-like appearance. So what that is, it's not a cancer, but it's something called laryngeal papillomatosis, which is basically similar to warts that we get on the skin caused by the human papillomavirus, except it affects the throat. And there are many different ways to treat this problem. We can do surgery in the operating room, but newer technology which is available at our center allows us to take care of these lesions in the office using lasers through our laryngoscope camera. And so here's a picture of us using a laser to basically zap the areas of papilloma in the office. And the patient tolerates this procedure very well after we've done a good job of numbing up the vocal cord. And we can turn the camera in a variety of different ways to get our laser exactly onto the vocal cord, so we can do a good job of treating this benign tumor. And you can see our pictures there of our laser. This is called a KTP laser, which is taken up by blood vessels, and it's what's called an angiolytic laser. And we can talk a little bit more about that a little bit later. So anyway, let's move on. So another patient, 55-year-old opera singer, presents to the office with a gradual worsening hoarseness of the voice, gotten worse, acutely worse as the practice schedule has ramped up and we see more fatigue. The patient was treated by an outside ENT doctor for something called LPR, which is basically reflux from the stomach and esophagus, and the acid doesn't stop at the esophagus level, but goes onto the throat. So the patient was treated with an anti-reflux medication called a PPI, or a proton pump inhibitor called omeprazole, and diet modifications, but there was only minimal improvement. And when I saw the patient, there was a significant hoarseness, strain, and two tones that I could hear with the voice. And so here's what, when I saw the patient in my office, we did a laryngoscopy and strobe procedure, and this is what we saw. We see this white lesion of the vocal cord, the right vocal cord, which is left on the screen. And we can see that lesion of the vocal cord. And so what that is, it's actually called a cyst. So this is a vocal cord cyst that is in the layers between the skin layer and the muscle and ligament layer. So it's what's called a subepithelial or sub below the skin cyst. And this is not a cancerous lesion, but this is something that can be thought of as congenital lesion, or something that usually exists from birth and slowly gets bigger over time. Some patients develop another lesion on the other vocal cord because of the trauma of the cyst hitting the healthy vocal cord. And so when we see these kinds of problems, we know that this is not a problem that can be fixed with voice therapy or medication. The cyst needs to come out. And so we use special instruments and a microscope and are able to use these techniques to remove the lesion in the operating room under general anesthesia. And I'm going to actually show you a video from the operating room of how we remove these types of problems. So you can see here, this is a very close-up picture of the vocal cord. The vocal cords are about the size of your fingernail, but this is going to be a very hyper-magnified video of our operation. Let's see if we can show. So we start the operation by injecting the vocal cord with some saline, and then we do a palpation with a special long instrument that goes through the mouth. Then we use a special scissor to cut through the skin layer of the vocal cord, which is called the epithelial layer. And what we do is we make a pocket between the skin layer of the vocal cord and the underlying ligament of the vocal cord. So we're now dissecting in what's called Reinke's space, or the subepithelial space. And this is kind of a sped up video, so this is not in real time, but this is basically us slowly and carefully dissecting the cyst out of the vocal cord. And the important thing with this operation is to leave the normal parts of the vocal cord alone and just take out the part that's causing the problem, which is the cyst. And this is our final little snip of the vocal cord, and we're basically leaving every little last piece of gelatinous layer behind so the vocal cord can heal nicely after the operation. And then this is what it looks like afterwards. So one of the things I want to impart to everyone is that we often see patients who are referred to us with reflux and things like that. But what is very important is not just to understand that reflux can cause voice problems and breathing problems, but it can also be another disease process. And many times patients refer to us for reflux that affects the throat. We find other alternative causes. So it's very important to take a look with the camera and watch the vibrations of the vocal cord. So here's another patient, 66-year-old patient, female singer, self-taught pop singer, comes in with, pain when singing and fatigue. She's preparing for a competition, performing for long hours, not too much warm up, not getting enough sleep, not getting good nutrition. When we listen to the singing voice, we hear that it's a little strained. And then we take a look with our camera and we see the vocal cords look a little bit different than what we've seen in the past. They look a little puffy, and we see some really thick mucus hanging out on those vocal cords. That's what we see, which is called vocal edema. And that happens with, you can call it traumatic laryngitis. And we see edema or redness of the vibratory margin, which is the part of the vocal cord close to the center, which vibrates. And this is something that we see quite often in singers and also in older patients as well. And so it's important to encourage healthy behaviors of the voice, hydration, humidification, proper warm-up, and proper cool-downs as well. So this is all something that we have our patients work with special voice therapists and singing voice therapists who can coach patients through these acute problems. I tend to avoid using steroids for these patients because steroids are only a temporary fix, and we want to help our patients in the long term and set them up for success. Steroids can help sometimes before important performances, but it's very much a risk-benefit discussion I have with the patients to make sure that we're doing the right thing and we're, again, setting them up for success. Steroids, again, have a role in acute edema, or acute swelling of the vocal cords, and all of that. So I'm actually going to kind of flip through a couple of these slides here and skip to this patient. So here we have another patient, 75-year-old retired lawyer, presents with a couple weeks of hoarseness, thinks maybe it started with an upper respiratory infection, maybe has issues with vocal projection in the courtroom. He also teaches having issues with getting his voice heard in the back row. Sounds a little breathy, a lot of air escape when he talks, and all of that. And so here's a picture of what it looks like when we take a look with the camera.
Excellent.
And so what we see there, I'm going to play it for you one more time.
Excellent.
So what we see there is a lot of floppiness of the vocal cord. The right vocal cord is able to move, and that's the left vocal cord on the screen. And the left one is almost in a static position, and you can see a lot of floppiness of the cover, the skin layer, because the muscle has atrophied over time because of it not moving correctly, and then the overlying skin layer looks more floppy against it. So this is called vocal cord immobility. So the vocal cords can be non-moving for a variety of different reasons. It could be a problem of the vocal cord joint from inflammation, from a trauma during intubation, or a rheumatologic autoimmune disease. Or it could be that there's a problem with the nerve that goes to the vocal cord, and that's why the vocal cord is not moving in and out properly. So all we know is that there's a problem with vocal cord movement. And why is it? So oftentimes we can attribute the vocal cord paralysis to a viral etiology, and sometimes we never know exactly what type of virus it was that caused the paralysis. Sometimes we see these patients who have vocal cord paralysis after surgery, thyroid surgery, anterior cervical spine surgery, carotid surgery, any surgery in the neck where there's operating around the pathway of that recurrent laryngeal nerve, which is that important nerve that innervates the vocal cord and causes the vocal cord to move. So when I see these patients in my clinic, number one, I try to figure out, well, what could be the cause? And if it's not obvious, like they had a recent neck surgery or a recent traumatic intubation with a breathing tube or something like that, then I need to find the reason. And what we always get is a CT scan of the neck to make sure that there's not a tumor or some mass that's pressing up against the nerve. And as I told you, that these nerves come out of the base of our skull and go into the chest or wrap around a big blood vessel in our neck and come back up and go to the vocal cords. And so we need to always make sure that that's not a problem. When I see patients with vocal cord weakness or immobility of the vocal cords, we always have a spectrum of things we can do to help. Number one, we don't need to do anything if the patient is okay with their voice. We can always observe and not do anything. Sometimes voice therapy helps with our speech pathologists, where they unload some of the tension in the voice box and try to use more breath support from the lungs to get a more efficient voice. Sometimes that's not enough, and sometimes we need to do vocal cord injections where we use a needle and plump up the vocal cord like you saw earlier. And this can sometimes be done in the office if the patient can tolerate it. And sometimes it has to be done in the operating room where the patient is put to sleep, and under a controlled setting, we can inject these vocal cords. These vocal cord injections are always temporary. The filler substance that we use eventually resorbs and goes away all the time. It's variable depending on what substance we use. And in certain cases, we elect, if the vocal cord paralysis lasts more than a year, we can do a permanent operation where we permanently move the vocal cord over using a surgery through the neck. And again, this is an example of how we do some of our injections. Sometimes I do the injection through the mouth with a long cannula and needle. And sometimes I like to do the injections with a needle through the neck skin. And I put the needle right above the Adam's apple, and then the needle comes out in the larynx, and I direct the needle into the vocal cord. Here's a video of us doing it in a patient. And you can see here the needle is gonna come out right in front of the vocal cord. I put a little bend in the needle, and then I inject push the needle into the vocal cord deeply into the muscle layer, and then I slowly inflate the vocal cord with our filler substance, and you can see that's kind of how it works. And then sometimes, like I said, we need to do a permanent operation. And so when the vocal cord paralysis lasts more than a year, and the patient has done well with an injection, and their voice got better, but then it got worse after the injection wore off, then we start talking about thyroplasty, which is a procedure where we make an incision in the neck and we dissect down to the thyroid cartilage, which is the cartilage that covers the vocal cord. If you were to feel your neck, it's the same cartilage where our Adam's apple is. And we drill a little hole in this cartilage, and then we put an implant in and push the vocal cord over. We do this in the operating room while the patient is partially awake, and we have a camera that's looking in at the vocal cords as we're putting the implant in. And we are titrating the amount of implant we put in with the patient's voice, so we make sure that we're putting in just the right amount. If we put in too much, we can get a strained voice. If we put in too little, the voice is still weak. So it's important to listen to the patient while we're putting our implant in. Of course, this is done with a lot of numbing medication on the neck, so the patient doesn't feel any pain during this operation. Here's an example of what a patient looked like before this operation. Let's see if I can get a good picture for you.
And breathe.
The patient's voice is very breathy and hoarse, and there's a lot of air escape and floppiness of the vocal cord. You can see right there.
Yeah, high E. And a low E. Good, and breathe. Just breathing in and out of the mouth. And another E.
So a very weak sounding voice, and this is after the operation. And And the patient has a pretty much normal voice now. And you can see the vocal cords are vibrating nicely and touching each other completely. There's no gap between the vocal cords. And so we're getting a nice, efficient voice. The vocal cord is nicely pushed over, but it's not overly pushed over. And so we have what's called a good, proper medialization.
One more nice strong.
And so the patient's very happy with the voice result after the thyroplasty. It normally takes several weeks and sometimes months for some of the swelling to come down after a thyroplasty procedure, but usually the patients do quite well. So again, there are hundreds of voice disorders that we could talk about in older patients, but it's important to understand the framework that we diagnose these voice problems with, and working with the patients to understand what their goals are and how they want to approach these problems. So again, voice problems can be multifactorial, different causes. The history and physical exam is important, just as important as the camera exam. I don't work alone. I have a big team, a multidisciplinary team of nurses, speech-language pathologists, singing teachers, music teachers, social workers, radiation oncologists, medical oncologists, pulmonary doctors, gastroenterologists. We all work together to optimize the patient's voice issues. So let's see here. It's important to understand that voice problems can be medically treated, behaviorally treated, and surgically treated. It's important to understand that all these things work together sometimes, and doing surgery can help voice patients, but oftentimes it's a combination of surgery as well as behavioral modifications that really make the best result for our patients. So with that being said, I will stop my discussion and I'll be happy to answer questions from the audience.
Dr. Dhar, this is John. Just a couple of quick comments. There were some people during your presentation who shot me private comments, and we had comments like "fascinating," "this is amazing," "what a great presentation." So just some really neat comments from people, wonderful videos, etc. The first question actually comes in. Please explain to the non-medical audience what is Zenker's diverticulum. Thanks.
Absolutely, absolutely. So Zenker's diverticulum is a disorder that results in swallowing problems. It could actually also result in voice problems too. And so what it is a problem of the upper esophagus. So the esophagus is a tube that connects the throat down to the stomach. There are two valves that are, one's at the top of the esophagus and one is at the lower part of the esophagus. When the valve at the top part of the esophagus is too tight and doesn't relax very well, pressure builds up above the valve at the top of the esophagus. And then pressure has really nowhere to go but kind of go backwards. And over time, a diverticulum or pouch forms behind the esophagus as a result of the tight, high pressure upper esophageal sphincter or narrowness. And so what happens is over many years, and oftentimes we see patients in their 70s or 80s who develop these pouches that form behind the esophagus. And so when patients swallow, food can get stuck in these pouches and it has nowhere to go because it doesn't drain into the esophagus like it's supposed to. And so this is what's called a false diverticulum, or basically a false pouch in the upper esophagus. And there are many ways we can treat these problems. We can do endoscopic approaches through the mouth, or we can do transcervical or through the neck operations where we cut out the entire diverticulum. Sometimes even after surgery, these diverticulums can come back, and patients may need 1 or 2 operations, but most of the time, patient swallowing and regurgitation improves dramatically after intervention. And these diverticulums can be anywhere from 1 centimeter to 5 or 6 centimeters in terms of how big they are. But that's how they occur.
Thank you, Dr. Dhar. The next question is a 64-year-old singer who would like to continue singing for the rest of my life. What do's and don'ts would you recommend both on a daily basis and before/after performing?
Yeah, I think that's a great question, and that's actually probably an even better question for probably some of my voice and speech language pathology colleagues who do a lot of work with rehabilitating singers. And so, what I don't pretend to be a voice, a singing coach or a speech language pathologist. But one of the things that our speech language pathologists really emphasize is care of the voice, care of the speaking voice, as well as care of the singing voice, paying a lot of attention to warm up as well as cool downs, taking care of our voice outside of singing, and that includes optimizing diet, reflux, avoiding smoking, controlling allergies, controlling reflux disease. These are all important things to keep the voice box healthy and hydrated and well lubricated. The speech language pathologists work with our patients to optimize the biomechanics of voice to get a more efficient voice that, with good breath support and less strain and less tightness of the voice box itself, and a more effortless voice production. And so that's a very kind of vague answer, I know, but oftentimes a lot of my patients who are singers, they don't require operations at all, or they don't require medications at all from me. It's oftentimes working with a voice therapist here at the Dance Center to teach them some techniques for care of the voice, hygiene of the voice, and proper technique and proper harnessing of the breath and the coordination of the breath with vocal fold function and movement. Anyway, so that's at least what I have to say on that.
Excellent. Would you recommend, another question is, would you recommend an evaluation for someone who frequently clears their throat?
Yeah, so throat clearing is I consider it something on a spectrum from feeling like there's a foreign body sensation in the throat, that is called globus, and then that can evolve to throat clearing, and that can also evolve to chronic coughing. Oftentimes, patients who have throat clearing, it can be from an organic cause, such as reflux disease or allergy, dehydration, but it also can be behavioral. It can be after an upper respiratory infection where the throat is hypersensitized from the viral illness. And then we develop this almost behavioral and habitual throat clearing and cough. And it often is helpful to treat the underlying causes of the throat irritation, be it allergy or reflux or dehydration. It's important to treat those things and then focus on ways to change the behavior of throat clearing and replace it with a more healthy behavior, such as swallowing or drinking. And sometimes we need to work with a cough suppression therapist. Sometimes we need to optimize medical comorbidities. And sometimes we even need to do things like give medications that help reduce the sensitivity of the throat. And sometimes even we need to do little injections next to the nerves of the vocal cord to help reduce the sensation and basically try to almost recalibrate the sensations of the throat. I often find working with my GI colleagues who help with reflux, like Dr. Johnny and the whole GI team here, and I also really get a great benefit from working with our pulmonary doctors like Dr. Slack, who really do a great job of optimizing other comorbidities.
Great. So the next question, thank you. I'm 80 plus and my voice has been raspy for about 2 to 3 years. My physician said it's due to allergies, but meds and nose sprays don't seem to help. If I talk all day, it seems to improve.
Yeah, I think in general, we see a lot of patients in their older years with voice changes. Like I said, every patient is different, and we need to evaluate them specifically. We need to understand what are their other comorbid problems. Do they have a smoking and drinking history? Are they having swallowing or breathing issues with that? We'd also want to take a look with our cameras to look at the voice box and see what's going on. Oftentimes, as patients get older, we see a few things. Sometimes if the patient is male, we see that the voice actually gets a little bit higher, and they're using a little bit of a different type of musculature to get voice out. We also see thinning of the vocal cords, just like in Parkinson's. In old age, we see vocal cord atrophy and thinning, and sometimes, and most of the time actually, even if we have thinning of the vocal cords and a weak voice, voice therapy actually works most of the time to help these patients. And probably in the rare case, do I do a procedure like a vocal cord injection or do a thyroplasty where we do an open procedure to push the vocal cords together. Again, I always start with a personalized evaluation of the patient. I always do an exam and visualize the larynx, rule out other problems, dangerous problems like vocal cord cancer or vocal cord paralysis or things like that. And then we tailor our treatment to what the pathology is. And again, always starting with the least invasive and moving our way up to the more invasive problems.
Thank you, Doctor. Next question. Would you please discuss your management of laryngoesophageal reflux?
That's a really great question. We see this diagnosis quite a bit, and I think people in this country, there's a great deal of people suffering from gastroesophageal reflux, where the symptoms are heartburn and regurgitation and acid brash. And so sometimes this acid can actually, or stomach contents, regardless of the pH of the stomach contents, can reach the throat, can cause hoarseness, foreign body sensation, throat clearing, all these different things. And so number one, what I like to do when I get a patient who may have reflux is I take a look in their throat. I look for generalized signs of inflammation. But as I said before, we have to realize that everything isn't reflux. A lot of things are, but a lot of things aren't. And we need to do a good exam to make sure we're not dealing with another problem. The signs of reflux are very broad and very nonspecific. Edema, swelling of the vocal cords, things like that. And so I very much like to get objective reflux testing. And what does that mean? It means we use special probes that can, sometimes we can use small probes that go from the nose into the esophagus that detect reflux. And we also are using small wireless capsules, which are called Bravo capsules, that are placed endoscopically in the EGD suite onto the esophagus. It attaches to the esophagus, and for a 48-hour period, detects reflux. And then the patients then correlate the reflux to their symptoms, and we can figure out, well, does this patient really have reflux, or is it something else? So this is something that I really like to get objective reflux testing, because again, the signs of reflux of the throat are very vague, and I like to have hard data before we start to prescribe medications for our patients and advise them to have surgery for reflux. And again, we have colleagues here at GBMC like Dr. Rotolo, who does reflux surgery, and we have our colleagues Dr. Johnny and the whole GI gang who test people for reflux and do Bravo probes and pH probes. And so, I think treatment of laryngopharyngeal reflux really starts with getting the right diagnosis, and then we can treat it with medications, lifestyle modifications, and sometimes minimally invasive surgery is the right option if people don't respond or partially respond to medication. So that's pretty much what I have to say on that.
So the last question on the chat is the accumulation of mucus in the rear of the throat cause for concern? It seems to be the cause of constant clearing of throat and difficulty swallowing at times. Would you recommend an evaluation?
Yeah, these are kind of problems that I do see a lot, and it depends how much it's bothering the patient. I always think about, we always want to make sure that there's no significant danger signs. Is there pain when swallowing? Is there weight loss? Is there a change in the voice? Is there breathing difficulties, coughing up of blood, things like that? If it's just mucus in the throat, usually if it's lasting longer than about 3 months or so, something that you may want to get looked at. And this can be, you can always start with your general otolaryngologist, and if they have difficulty finding the cause of the mucus, and we can always get further evaluation either by looking at reflux as a cause, looking at allergy and as a cause, and sometimes even patients with dehydration, we can see this. Sometimes patients with neurological conditions can have buildup of mucus in the throat. So it can be a variety of different things. I think it really depends on how long the symptoms are lasting, how bothersome it is, and if it's being associated with any other danger signs. But usually accumulation of mucus in the throat is not necessarily dangerous on its own.
Thank you, Dr. Dhar. Unfortunately, I just got word that we're not able to unmute the phone, so I apologize for that. But I did want to thank Dr. Dhar for this fascinating and really engaging presentation and insightful answers to all these questions. We're so fortunate to have you at GBMC. Thank you so much for giving up your valuable time. And we usually give our presenters at the Laycock Perspectives in Medicine series framed certificate signed by our president and CEO, Dr. Chessar, to commemorate the event. Since we're doing this virtually, we'll be sure to personally deliver that to you, Dr. Dhar, at your office after today. So thank you again for sharing your expertise in this compelling presentation, Dr. Dhar. I really appreciate you being here today.
Yeah, thank you so much. It was really great to be able to, give a little overview of what we do here at the Dan Center. And I want to thank you, John, and thank Morgan and everybody who helped make this possible. And I want to thank the team here at GBMC and my staff here, and all the speech pathologists, nurses, head and neck surgeons, everybody who works to help care for our patients. So thanks again for the opportunity.
Absolutely. And one of the marks of a presentation that was really enjoyed by a lot of questions. We had a lot today, so thank you for everyone who participated. I'd also like to take a moment, as Dr. Dhar just did, to thank my associates here at GBMC for all their help, especially Morgan Varley, who really handles the lion's share of the logistics of these great events, especially getting the goodie boxes delivered to everybody today. Thank you, Morgan. Meg Ryan, Margaret Harley, Christina Wales, and Philanthropy GBMC, Philanthropy VP Jenny Colnar. To all of our loyal attendees, our next Dean C. Laycock Perspectives in Medicine lecture will be on Wednesday, April 7th, when Dr. Alpin Patel will rejoin us in the midst of the spring allergy season to discuss sinus problems during the peak hay fever time. We hope you can join us again virtually or maybe even in person. Please keep an eye on your mailbox for your invitation and more details. So thank you again, Dr. Dhar, and thanks to everybody for attending today's lecture and thinking of GBMC as our community's healthcare system. Have a happy and safe holiday season. Happy Veterans Day, and we'll see you in 2021.